So I have the unique opportunity of introducing Dr. Sonam Puri, and she is with Moffitt Cancer Center. So let's welcome her.
Thanks so much for having me here, and thanks to Delta for finally getting me here. So today, I'm going to really talk about what do we have in our pockets in the medical oncology clinic to treat a patient with small cell lung cancer. And I want this talk to be very, very interactive. Please feel free to ask me any questions. This is just looking at what we are able to offer right now as a medical oncologist for our patients. So I think this is the big focus, right? Why do we need to talk about small cell lung cancer more? Small cell lung cancer only happens in about 15% of cases of lung cancer that are diagnosed, but it's extremely aggressive. Even 10% of EGFR mutated non-small cell lung cancer transforms to small cell. It's a highly aggressive malignancy. Majority of patients, when they are diagnosed with end-stage disease. We are making improvements, but still 5-year survival of only 12%. And it's highly responsive to the first type of treatment we give, but then inevitably resistance develops to that, and we definitely need to do a better job of subsequent lines of therapy, which we are getting there, but not quite there. And these are some of the agents that I'm going to focus on and what has changed. I'm not going before 2019 because there was a lot less that we had in our pocket at that time to offer. But starting 2019, we've really started seeing some good drugs come to the clinic that have made meaningful change in our treatment strategies. And starting with immunotherapy, the first immunotherapy was approved in 2019 for first treatment of small cell lung cancer. Then Lurbinectedin, which is a treatment that damages the DNA of the cancer cell, which was approved in 2020. And then more recently, we've seen immunotherapy move to earlier stages of disease. We've seen approval of Tarlatamab, which is a targeted immunotherapy, and also an improvement in supportive care, protecting the bone marrow when you're getting treatment with small cell lung cancer through drugs like trilaciclib. So what is an immune checkpoint inhibitor? And just as I say it, I see that I've mispronounced immune here. But what is an immune checkpoint inhibitor? What does it really do? All of us have soldier cells in our body. Those soldier cells fight cancer on an everyday basis, but cancer knows how to outsmart the immune system by putting brakes on the immune system. And what immune checkpoint inhibitors do, they break those checkpoints. So they allow your own immune system to fight the cancer. And currently we have different types of immune checkpoint inhibitors approved for lung cancer in general, but in small cell lung cancer, we have PD-1, PD-L1 directed therapies, which is a scientific name of the checkpoint that is removed. And what we saw for first treatment of small cell lung cancer when it's diagnosed in the stage 4 disease is then when we added immunotherapy, immune checkpoint inhibitor to chemotherapy and compared it to chemotherapy alone, we saw a meaningful improvement in survival. We saw that people lived longer. We saw that there was a tail to the curve, that once response was achieved, it lasted for a longer time. And these were just the 2 studies that I've highlighted here, which made this change possible and really introduced immunotherapy into our clinic. And the drugs that are approved are atezolizumab, which was through this study known as the IMpower study, and durvalumab, which was approved through this phase 3 study known as Caspian trial. And then durvalumab did not end its journey with the Caspian study. I like to put this as a way of just humorously describing the journey of durvalumab in small cell lung cancer, which started with extensive stage disease, which is when cancer spreads outside the lung to limited stage disease now when cancer is restricted in the lung, where we have seen benefit with durvalumab. This is a very, very recent study which was published within the last year, approved within the last year, which is looking at giving, after somebody gets diagnosed with small cell lung cancer in the lung, it's treated with chemotherapy and radiation. There's a good response to give them an additional year of immunotherapy. And what we see with that is, again, there is an improvement in the overall survival. People live longer, people are cancer-free for a longer time, very meaningful. We are doing this in clinic all the time now. But there's still an unmet need, right? It helped us achieve, got us a few steps ahead, but then there's still an unmet need with immune checkpoint inhibitors. It helps, but it's not enough. It boosts immune system to fight the cancer, but overall the improvement is about 2 months. Unfortunately for most patients, cancer still returns. And why is immunotherapy specifically not able to meet all the needs of small cell lung cancer? Because small cell lung cancer, even compared to lung cancer in general, knows really well to hide from the immune system. It grows quickly, it hides from the immune system, it makes it harder for immunotherapy to work. And there's no clear way right now to know if you have small cell lung cancer, who's going to benefit compared to who's not going to benefit and is going to get side effects as well. The markers that we use for another type of lung cancer known as non-small cell to predict how well you're going to do with immunotherapy don't work that well in predicting how well somebody does with immunotherapy for small cells. So there's a lot of work we need to do here. And that gets me to the second drug, which was approved in 2020, which was Lurbinectedin. This is a type of chemotherapy that was approved in 2020 based on the effect that it showed in a patient with small cell lung cancer who had progressed on the first type of chemotherapy, and this was the second or beyond chemotherapy that was given. Lurbinectedin works by targeting the DNA of the cancer cell. It also reduces inflammation in the area around the tumor, which makes the treatment more effective. And this drug was initially studied in a smaller group of small cell patients, where it showed really good effect in a very hard to treat disease, and based on it, it was given an accelerated approval by the FDA. And currently, the confirmatory studies to make it more mainstream in clinic are ongoing and hopefully are going to be positive. However, it gave us one more thing in our pocket to treat with small cell lung cancer, but it still left us with unmet needs. And what were the unmet needs? Lurbinectedin provided modest benefit. It was able to shrink tumor in some patients, but did not work for everyone. Patients whose cancer returns quickly, we categorize somebody with small cell lung cancer into two types of diseases based on how quickly the cancer returns after first type of chemotherapy. And if it returns more quickly or less, more further away from chemotherapy, if it returns more quickly, it's more aggressive. So we saw with Lurbinectedin, for a patient who cancer returned quickly after chemotherapy, it didn't work that well. The responses were better than before, but they were still short-term. There was again no way to predict who's going to do better and who's not going to do that well. And then some of the side effects with this medication can be difficult to manage. Particularly, it causes fatigue, low blood counts, increases risk of infection. These are very, very challenging for an immune system that has already seen chemotherapy has been affected by it. So unmet need here again. And right around this same time, a medication, not so much for treatment of small cell lung cancer, but this was a drug which was approved to support the bone marrow of somebody who's undergoing treatment with small cell lung cancer, which is trilaciclib. This is a drug that protects the rapidly dividing cells in the bone marrow that eventually lead to the blood counts going up after they've gone down after chemotherapy. And there were several studies with this medication that showed when this is given in combination with chemotherapy, it makes the side effects of chemotherapy less. And based on that, the FDA approved this medication for reducing the frequency of chemotherapy-induced bone marrow suppression. And this has been really something that has come on all guidelines, something that should be considered for anybody who's getting treatment with small cell lung cancer, particularly the first type of treatment, the first line of treatment that's given. So these are the options we really had over the last, from 2019 to 2023. What is really new, what is shown a promise that was not shown before, and I hope builds more promise as we learn more about this drug, is Tarlatamab. How I describe Tarlatamab is it's a targeted immunotherapy. So, as I mentioned before, small cell is smart. It knows how to hide from the immune system. But what if we find something on the surface of the small cell, which is present in majority of small cell, and make a drug that sticks to that part and also sticks to the immune cell, and then just artificially brings them together. So you cannot hide anymore. We're going to get the immunotherapy to the small cell, and this is what this drug does. It's the fancy term for this is a bispecific T cell engager, which means bi means like one part attaches to the small cell tumor, one part attaches to the T cell, and then brings it together, makes the T cell kill the cancer, which is a drug which was recently approved for treatment of small cell lung cancer. It really redefined what was possible with small cell lung cancer. This drug, which was tested in just over about 100 patients with small cell lung cancer, showed impressive response in somebody who's received many treatments for small cell lung cancer. Response rate means tumor shrinkage or tumor disappearance in about 40% of patients, controlled the disease in over 70% of patients. When you did respond to this treatment, the response lasted for much longer than what we've seen before, an average of 9.7 months. And on an average, patients who were started on this treatment lived for over a year, which is right now even longer than what we are able to offer for first-line treatment. So I definitely think the numbers are still, something that keep us really, really grounded. We just need to achieve so much more, but this is so much better than what we've seen in the past with small cell lung cancer treatments. But that does come with a cost. This is a drug that does come in with side effects. This is an artificial engagement of the immune system to fight the small cell lung cancer. And with that comes the two most common side effects that are seen with this agent. Basically, the way I describe it to my patients who are sitting in clinic, it's just like how things used to happen with COVID. It used to overwhelm the immune system. This can also overwhelm the immune system because you're engaging the immune cells. And it could be something as simple as fatigue, just feeling like you have the flu that goes away, or it could be something which is more serious, in which basically when certain inflammatory markers are released from the blood, they affect the blood pressure, they can make the oxygen supply go down, can lead to multi-organ failure, including confusion and effects on the brain. But fortunately, the side effects with this medication were overall although overall they were 50%, they were low grade, means that they were very manageable, at least when it was seen in the clinical trials. But what is important is early identification of these side effects so that we can monitor and promptly give treatments to prevent it from going from low grade to high grade, which is something that I'm going to cover over the next few slides. So this is just the journey of Tarlatamab from when we first heard about this drug and how effective it was in small cell lung cancer, and then FDA granting accelerated approval for this medication just about the same time, this time last year. And we were fortunate at Moffitt Cancer Center to have a team ready for this. We do cater to a pretty large population of patients with small cell lung cancer. We knew that we had to be ready for this medication as soon as it was approved. And within a week of FDA approval, we were able to treat our first patient in the US. I think it's probably the first commercial patient in the world at this time, successfully with a great team of blood doctors and solid tumor doctors who all got together to make this happen. But we've learned quite a few things within the last 10 months with Tarlatamab. Whenever we see excitement with the drug, we want to make sure that once it's approved, we are able to give it not only to the cancer it's approved for, or at least we try to give it for other cancers in which we think it could be potentially beneficial. And what we've seen with Tarlatamab is it's not only shows effect in patient who has small cell lung cancer, but also a similar type of cancer that has very less treatment option known as large cell neuroendocrine carcinoma of the lung. There have been case reports that have been published now that this drug is effective. It is also effective in decreasing the size of cancer in the brain. Historically, patients who had cancer growing in the brain were not part of the trial that got Tarlatamab approved, but once it gets approved, we are able to give it and see that effect. And this is an initial study that has come out of MD Anderson that shows that without the use of radiation, Tarlatamab just by itself is able to shrink cancer growing in the brain for a subset of patients, which is definitely promising. So these are the rewards. There definitely have been challenges as well. Over the next 3 slides, I'm going to cover really the first few reports of real world, as we call it, safety of the medication. And just a disclaimer here, these are really small numbers. And when you take ratio of any small number, it appears to be bigger, but it definitely helps us plan how to make it more safe in future. And this was a study which was presented by my friend and colleague, Dr. Desai, from the first 14 patients treated at UAB with small cell lung cancer with Tarlatamab, in which they saw a higher incidence of side effects than what was reported in the clinical trial. Similar experience with MD Anderson in their first 31 patients, but what they saw was they were able to manage side effects in majority of their patients, but they actually also saw the good effect in the brain, like I mentioned, and the good effect of the drug, which is shrinkage of the tumor seen in the MD Anderson cohort, was higher than what was in the trial. So a higher number of patients responded to Tarlatamab than what has been shown in the trial as well. And very recently, we've presented our experience, our first 31 patients treated with Tarlatamab. In the first 20 patients, initially when we treated with this medication, we saw a lot more side effects than we expected, but these were also patients who were waiting for this drug for too long, and just when it got approved, they got treatment. But based on what we saw, we rapidly identified certain risk factors that make you a higher risk to develop those side effects. And we at Moffitt have developed a protocol to give certain medications before Tarlatamab to make it safer in a subset of patients. And that's what we are doing. And after we've done this, our side effects have decreased quite a bit. And I think this is really important. Innovation doesn't only lie in finding new drugs. It also lies in making sure that those drugs are effective and are able to get to the maximum number of patients. These are right now only being, this medication is currently only being given in bigger centers that have an ability to monitor the patient, but that introduces so many roadblocks to treatment. Nobody wants to travel 3 hours to get a medication. Nobody wants to stay a day extra away from their home. And if we are able to develop strategies to make medications safer, we'll be able to give it to more patients, and this drug is definitely promising. We're looking forward to develop protocols so that it is to be able to give it more commonly in the community, for sure. And we didn't stop here. You saw, I basically told you 3 centers published their experience, right? These are small experiences. I think the the power lies in when we combine our numbers, when we combine our expertise. And to make that happen, we at Moffitt Cancer Center, I'm the lead PI for this, have formed a consortium of cancer centers to study all our small cell lung cancer patients together. So we are able to produce meaningful data with meaningful numbers to look at our experience, to look at what worked, what did not work. And this is our ONWARD Small Cell Lung Cancer Consortium, which is an observational network for advancing real-world data in small cell lung cancer. We are starting currently with studying our Tarlatamab treated small cell lung cancer population because there are a lot of unanswered questions. They are just a snap of the institutions that have agreed to be part of this consortium. But what we are really looking at is answering real questions that sometimes the trial does not give us an answer for, but we need that in clinic. This is just a very, very small list. I can tell you this consortium is already looking at 9-12 different projects. But we want to see what is the effectiveness of this treatment for somebody who doesn't have pure small cell lung cancer, but small cell lung cancer mixed with some other cancer, which is also treated like small cell lung cancer. We want to know the effectiveness of this drug in large cell neuroendocrine tumors. We want to know the effectiveness of this drug for a small cell that did not come from the lung. This is a really, really unmet area of need because this population is not studied in clinical trial. We want to have a larger data set to study the effectiveness of Tarlatamab for small cell lung cancer in the brain. We also want to look at each of our CRS and ICANS, that side effects that I mentioned about for Tarlatamab. What are we doing to make sure that it doesn't happen, or if it happens, we're able to identify and treat it. So we're going to focus on that as well. So a lot of work for us. Tarlatamab has given us a lot of hope, but it has still left some areas of unmet need, which we all as a medical oncology research community need to address. It does have a longer time to onset. It takes about 1.5 months for the drug to start working. Some of our patients don't have that time. So maybe we combine it with something to make it more effective. I don't know, but we need to work on that. There is limited data on the specific populations that we mentioned. We definitely, I think if once we get more data, we'll be more comfortable with answering questions about how effective it is going to be in a particular patient. It certainly right now has limited availability and access, although it's improving rapidly. And we definitely need to develop markers to predict both response and toxicity to this therapy with all the promise that it has to offer. So with that, I'm not covering what is going to happen as a future of small cell lung cancer treatment, but I wanted to really put this slide, which is courtesy my friend Dr. Shields. She summarized it pretty well in an earlier talk of hers, in which she basically summarized trials that are improving on existing treatments, improving by combination, improving by changing the mode of delivery from IV to subcutaneous, improving by addition of radiation. So there's a lot of work that's happening in this area. But what I don't want the focus to go away from is supportive care. It is extremely, extremely important to have an umbrella of supportive care in addition to any treatment that's given for small cell lung cancer. So from my end to my patient community, what I have an ask for you is, if you're not offered, you should all be offered these services. But if you're not offered, ask for an earlier involvement of supportive care team. They are really good with what they can do as far as symptom management is concerned. Ask for early involvement of the social work team for support for both you and your family. Ask for early involvement of nutritional services. One of the biggest things that I see my patients ask me about is like, my appetite is low, what should I do, right? There are strategies. You might not want to have that full meal, small frequent meals, how to increase the energy density of your meal. If we start working on it early on, we will be able to at least decrease the effects of treatments leave on us with low appetite and loss of activity. And in summary, I would just like to say we all know small cell lung cancer is very aggressive. It grows quickly, starts in the lung, spreads to other parts of the body. Other types of cancer can transform into small cell. And the big problem remains that even though it responds quickly to the initial treatment, it has a very high ability to come back with limited survival at that point when it returns. In recent years, we've seen several new therapies for small cell, and I promise you with the work that is being done, you're going to see a lot more. But all of the treatments are right now associated with some limitations. Newer therapies offer hope for a longer outcome with better quality of life. But early initiation of supportive care is extremely important. It is all about prolonging life, improving the quality of life, and supportive care really helps us achieve that. And as a patient community, my ask from my community is to participate in clinical trials, but ask why this trial? Why is this trial right for me? It's very important for you to know why your doctor thinks that this trial might work for you. And at different stages, different trials might hold a promise for treatment completely. Stay informed, engage with your healthcare team. I always tell my patients, no question is not important. Every question that you have is important. Note it down, ask me. I'm here to answer those questions. And definitely, the fact that we are all here, we are supporting research and advocacy, but I can't stress enough how much we learn from everybody's experience as a team. And with that, I would also like to advocate for an organization that has helped me support myself as a thoracic oncologist, but is doing so much more for patients, so much more for caregivers, which is IASLC. And we would love to, have everybody join. It's free for patient advocates. It's free for caregivers. It really gives a bunch of support, a bunch of educational resources. It has definitely helped me change my career trajectory from being a medical student, fellow, and now a thoracic oncologist. And this is my little one who loves his spring photo shoot, and I just wanted to leave everybody with. Yeah.
Okay. Thank you, Dr. Puri. Thank you. And I'm so glad that you mentioned IASLC because it is free for patients and patient advocates. So please do join that organization. And they have a fabulous STARS program that Dusty and I are both alumni of. Free, again, totally free. So thank you for mentioning it. Thank you. Questions? Raise your hands. I see.
Yeah.
Is there a website? Yes.
I can send the link for the membership website, and I can also get you connected with the membership committee.
Yep. Thank you. Thank you. I'll make sure. Yeah, and if you don't have it, I'll let you know. I'll happily share it with you. Yep. Thank you.
Oh, yeah. Sorry about that.
Other questions for Dr. Puri? Huh? This is a first. I can't believe oh, good, Robin, good.
So, sorry. When it comes to all the different currently approved lines, like second, third lines, and ones that are going to be, is it something where, see, my mom's oncologist hasn't even talked about beyond this, the first line. Isn't it a good idea to try and advocate to get that, not set up, but like almost to see that it's most of the time needed? Can you be proactive in getting those things taken care of so that you can just jump right into it?
Yeah, so is the question that, setting up the next lines of treatment while you're on first line? Yes, absolutely. So that's what we use, so working in an academic center, we cater to a big community of community practices as well. And right now, our big community practice, for example, in Florida is Florida Cancer Specialists. It's huge, but they do not have the ability to give Tarlatamab. And when we meet them or when I talk to any of my community partners, I tell them, please have the patients see us when they're on their first line of treatment, because we want to know them, we want to identify any issues that they would have for treatment, and that's what we advocate for. So patients actually come and see us in first line, and when they need it in second line, we just like phone call away, right? Like it's not, there is no time to waste at all. Yep.
Great. I just wanted to mention also that I really appreciate you including that supportive care information, because a lot of people, they associate palliative care with hospice, and although palliative care is a component of hospice, palliative care should, and you said early. I love that. Early on, every lung cancer patient should be offered, or have access to palliative care, and they help with symptom management, whether it's the management of the cancer or the symptoms from the treatment, but very important, so thank you for doing that.
I have a quick question, a request, I guess, is what it, maybe it's more a request. This is my 3rd year here, and every year wonderful people like you give of your time to come and explain these things to us. And quite often you bring these graphs and charts that if we really want to save them, we have to use our little phones to take a picture. My suggestion for the future for you and for everyone is, can you bring printouts of these things?
Absolutely.
Thank you.
These the presentations are recorded, and if and they are on our YouTube channel, and so you'll be able to view them, and
Yeah, somehow the barcode is not coming up again, but I'm happy to send it the entire slide so it can be used. Yeah. So that you can see it right in front of you. Yeah.
Yep.
Yeah, I think that's a wonderful idea.
Made a note taken for
One more question.
2026. Yeah.
One more question here.
I would like to know how you came up with the 4 months. When I first started learning I was going on a new medication, I read some of it, and it said that it could take 6 weeks, 2 months. Some people are too sick to go on it. They can't wait that long. What determines that?
Sorry, I missed the earlier part of your question. I was trying to address a question here, but if you could repeat your question, I'm so sorry.
It's the 4 months of waiting until it's effective, or is it 6 weeks, or is it 2 months? I've read the different.
Is the question about Tarlatamab?
Yes.
Okay, yeah. So Tarlatamab is it's 1.5 months median time to onset. What that means is when they looked at all the people who had were on the study, and they looked at the average amount of time to their first scan in which there was a response to treatment, the average was 1.5 months. So I think the difference is between median time to onset of response, which is 1.5 months, and median duration of response, which is more in that, how long are you going to respond, which is more in that 6 months, 7 months, 5 to 6 month mark. So the difference is that really what it is, it's the time to the first scan, because what we do in the community is, or in our practice, is that the first scan, unless you are having symptoms of cancer growing, my first scan is usually in the 6 to 8 week period mark, because that is the amount of time it takes for a drug to work and for me to know if it's effective or not. If it is not effective and the cancer is growing before that, you're going to have symptoms. And if you have symptoms, I'm going to I don't follow that 6 to 8 week rule, and then you're going to get a scan earlier. But for me to say something is working or not, 6 to 8 weeks are minimum needed. And in the study, they found that approximately that was the amount of time that was needed for that drug to give you a response. Sometimes we don't have that time, like we were mentioning, there's just not enough time when you're going from one doctor to the other, if that is needed. And that is where I have run into trouble with Tarlatamab. But the issue is that it's not that it's Tarlatamab or something else, right? So a lot of times that is what we have, and that is the most promising agent right now. But sometimes what I have kind of requested our community doctors to do is to start on chemotherapy, to not have that time in which basically by the time you come to clinic, you're not able to get the Tarlatamab. There's some thought about this, and should we be going through chemotherapy and using one more type of treatment that we could have gotten afterwards. But my thought on that is my job is to save you now. What is going to happen afterwards, I'm going to tackle that. But if some sort of a bridging treatment is able to get you to a treatment that looks promising right now, I would like to do that.
Hello.
Sorry, great talk, Dr. Puri. So I was just going to add to that comment about Tarlatamab, and it's like you said, it's objectively once we get the first scan, which on the trial was 6 weeks. A lot of us do 6 weeks, 2 months, but it doesn't mean that it's not working in the meantime. So I've had patients that their cancer-related pain, that something that was just couldn't figure out what it was, immediately go away in the first week, or flashing lights in their vision that went away from brain mets in the first week or two. And so we do see, or even painful lymph nodes that swell because the immune system goes there and then it goes away and gets better. And so it doesn't mean that you're not having clinical benefit, it's just those are the times of the first scan that we can say that the scan will show. So it's not necessarily it's not working until it gets to 6 weeks, just to clarify.
Yeah, and it's also an average, right? For some people it works faster than for other people that could take a longer time. But honestly, if it is not working, you're not going to wait 6 weeks to know about it, for sure, for the most part.
I'm sorry, we do have at least another question.
I'm currently on Tarlatamab, and I started after being tested for it for 3 weeks. And I've had, my next appointment, it's like every 2 weeks. And the worst thing about it I have is I can't taste anything anymore. My mouth gets really dry, and I've lost so much weight. I used to weigh 300 pounds, which is a lie. A joke, I'm just kidding. But I've lost about 50 pounds since I've started this whole cancer thing. But this was the last one. Can I get any of those side effects to wear off, or will they always be there?
So this is a very, very difficult question, actually, because this is a very difficult situation that, once Tarlatamab is working, I don't know what's your experience, Misty, in your clinic, is I'm seeing taste dysfunction, which is what you're describing. And what has been described in literature to help with that and has helped some of my patients is artificial saliva, basically sucking on lemon drops or cloves. There are some of just basically a way to stimulate your palate. But it is a side effect that I think definitely needs more attention than what it has right now, because the scenario you're describing, loss of appetite, basically not being able to taste, and then losing weight because of that is something that I'm seeing a lot more in clinic. But those are the strategies that I'm using is yeah, and what I tell my patients also is at that point, for some of them it has gotten better over time. And what I tell them is using the same thing, high density, high energy drinks, so that at least you're able to maintain your protein and caloric intake while you're dealing with the side effects. Thank you so much. Thank you.